Imagine every cell in your body has tiny locks on its surface, called receptors. Most substances floating through your bloodstream are just keys that fit the lock but can't turn it. But some special molecules, called agonists, are keys that not only fit the lock, but actually turn it and open the door. Today, we're going to explore one of the most fundamental concepts in pharmacology: agonists, what they are, how they work, the different types, and why they matter in medicine. So, what exactly is an agonist? An agonist is a chemical, also called a ligand, that binds to a specific receptor and activates it, producing a biological response. Think of it this way: agonist is the sum of bind, activate, and produce effect. Agonists mimic the actions of substances your body already makes naturally, like neurotransmitters and hormones. For example, the drug morphine mimics your body's own natural painkillers, the endorphins. For a molecule to be a true agonist, it must have two essential properties. First, affinity. This is the drug's ability to bind to the receptor. High affinity means the drug binds effectively even at very low concentrations. Second, efficacy, also called intrinsic activity. This is the ability, once bound, to actually trigger a biological response. It determines the maximum possible effect, known as the Emax. Here's the key takeaway: binding alone is not enough. The drug must also activate the receptor to produce a response. No efficacy means no effect. It's that simple. Not all agonists are created equal. Let's walk through the main types. Type 1. Full agonists. A full agonist produces the maximum possible response when it binds to receptors. Key characteristics: high efficacy, can achieve a full response even without occupying all receptors, thanks to what we call spare receptors. More on that shortly. Classic examples: morphine is a full agonist at opioid receptors, and adrenaline, a full agonist at beta-adrenergic receptors. Type 2. Partial agonist. Partial agonist binds to the receptor, but produces only a submaximal response, even when every single receptor is occupied. Lower efficacy than full agonists, cannot achieve the maximum response. Here's an interesting twist. In the presence of a full agonist, a partial agonist will compete for the same receptors and actually reduce the full agonist's effect. In this context, it behaves like a functional antagonist. Examples: buprenorphine, used in pain management and opioid dependence, and pindolol, a beta-adrenergic partial agonist used in hypertension. Type 3. Inverse agonists. This one surprises many students. An inverse agonist binds to the same receptor as a regular agonist, but produces the opposite effect. How? Some receptors are naturally active even in the absence of a ligand. This is called constitutive activity. An inverse agonist suppresses this baseline activity. Examples: many antihistamines, such as cetirizine and loratadine, are inverse agonists at H1 receptors. And flumazenil reverses benzodiazepine sedation at GABA-A receptors. Type 4. Superagonists. Superagonist produces a greater than normal maximal response compared to the body's own natural ligand, with an efficacy exceeding 100%. Example: some synthetic opioids like fentanyl can behave as superagonists at opioid receptors, which helps explain their extreme potency and danger in overdose. Type 5. Selective versus non-selective agonists. Finally, agonists can be classified by their target specificity. Selective agonists act on a specific receptor subtype. Example: salbutamol targets beta-2 receptors in the lungs, minimizing cardiac side effects. Tamsulosin targets alpha-1 receptors in the prostate. Non-selective agonists act on multiple receptor types, producing more widespread effects. Example: adrenaline activates both alpha and beta receptors throughout the body. How do we measure what an agonist actually does? Through the dose-response relationship. When we plot drug concentration against the magnitude of effect, on a linear scale, we get a hyperbolic curve. On a logarithmic scale, we get a beautiful S-shaped, sigmoidal curve, which makes it much easier to compare different drugs. Two key values to know: EC50, the concentration of the drug that produces 50% of the maximum response. It tells us about potency. A lower EC50 means a more potent drug. Emax, the maximum effect a drug can produce. It tells us about efficacy. These two terms are commonly confused. Let's clear that up once and for all. Potency is about how much drug you need. A more potent drug achieves the same effect at a lower dose. It is measured by EC50. Efficacy is about how strong the maximum effect is, regardless of dose. It's measured by Emax. A drug can be highly potent, but low in efficacy. It works at tiny doses, but can't produce a strong effect. Less potent, but highly efficacious. It needs more drug, but can achieve a powerful effect. When choosing a drug for treatment, efficacy determines whether the drug can do the job. Potency just determines the dose you'll need. Here's a fascinating concept: spare receptors. A system has spare receptors when the maximum biological response can be achieved by activating only a small fraction of the total receptor population. This increases the cell's sensitivity to low concentrations of an agonist. Real-world example: in the heart, activating only about 1% of beta-adrenoceptors is enough to achieve maximal contractility. The other 99% are spare. Spare receptors are a built-in safety buffer, and they're a hallmark of high-efficacy agonists. How does an agonist actually work at the molecular level? Let's walk through it step by step. Step 1. Binding. The agonist binds to the receptor's active site, the orthosteric site, or an allosteric site. Step 2. Conformational change. Binding forces the receptor protein to physically change its shape. Step 3. Signal transduction. This shape change triggers second messengers, like CAMP or calcium ions, or directly opens ion channels. Step 4. Biological effect. The cell responds. Muscle contracts, a gland secretes, and a neuron fires. The main receptor pathways involved include G-protein-coupled receptors, GPCRs, ion channels, and enzyme-linked receptors. The body doesn't just passively accept agonist stimulation, it adapts. Downregulation. With chronic agonist exposure, cells decrease the number of receptors available, essentially hiding them inside the cell through a process called internalization. This reduces sensitivity over time. Desensitization. Tachyphylaxis. A rapid waning of response, often caused by phosphorylation of the receptor, which uncouples it from its signaling proteins. This is why medications like nasal decongestant sprays or nicotine become less effective with repeated use. Let's briefly touch on 3 advanced ideas that are shaping modern drug development. First, let's look at biased agonism, or functional selectivity. A full agonist hits a receptor and activates every pathway available, like a master key opening every door in a hallway, with both pathway A and pathway B fully lit up. A biased agonist, by contrast, is a smart key. It binds to the receptor, but shifts its shape so precisely that it only unlocks pathway A. Why is this a major goal in drug design? Imagine an opioid designed to trigger the pathway for pain relief while completely avoiding the pathway that causes respiratory depression or nausea. By being biased toward the beneficial signal alone, we create medicines that are far safer and more effective. Next, we have allosteric modulation. Most drugs bind to the orthosteric site, the front door. But receptors have side doors called allosteric sites. Take benzodiazepines. They act as positive allosteric modulators, PAMs, at GABA-A receptors. Rather than activating the receptor themselves, they act as a volume booster, amplifying the signal when the body's own GABA arrives. Conversely, a NAM, negative allosteric modulator, acts as a muffler, weakening the signal even if the drug is bound. This gives us a dimmer switch instead of just a power button, allowing us to enhance the body's natural chemistry without taking over the steering wheel. Finally, we have the two-state model, which explains the baseline of our bodies. Receptors naturally flip-flop between an inactive state R and an active state R star, creating a small amount of background noise called constitutive activity. A full agonist shifts the balance entirely toward the active state R star, maximizing the signal. A partial agonist is more subtle. It shifts the balance toward R star more than the baseline does, but it never fully pushes the receptor into that active state. No matter how much of the drug you give, it only produces a moderate response. A neutral antagonist is unique because it has equal affinity for both R and R star. Now, you might be wondering, if an antagonist blocks a receptor, why do we put it on the same scale as agonists? It's because in modern pharmacology, we don't just ask if a drug binds, we ask how it shifts the balance. Although it is neutral regarding the signal, it is still considered an antagonist because it occupies the receptor. By doing so, it prevents the agonist from binding, which would otherwise alter the balance. It blocks the change without initiating any effect itself. But the inverse agonist is the most unique. It doesn't just block the signal, it actively shifts the balance toward the inactive state R, suppressing the signal below the natural baseline. Now, let's see some clinical applications. Agonists are among the most widely used drugs in medicine. Here are key examples. Salbutamol receptor target is beta-2 agonist, insulin receptor, ropinirole and pramipexole, dopamine receptors, dopamine and noradrenaline, adrenergic receptors, and morphine, opioid receptors. Like any pharmacological tool, agonists have both strengths and limitations. Advantages: directly produce the desired therapeutic effect, ideal for replacement therapy, mimicking what the body is missing, predictable, since they use the body's own signaling pathways. Modern agonists can be highly selective, minimizing side effects, and effects are often titratable, easily adjusted by changing the dose. Moving to the limitations, overstimulation can lead to toxicity. Tolerance develops with long-term use due to receptor downregulation. Even selective agonists can affect receptors in unintended tissues. Finally, dependence and withdrawal can occur if the body reduces its own natural ligand production in response. Agonists are the molecules that say yes to receptors. They bind, they activate, and they drive biological responses, whether naturally in your body or as therapeutic drugs designed to help you heal. Understanding agonists is the foundation of pharmacology. Master this and the rest. Antagonists, drug interactions, receptor theory will fall into place. Thanks for watching. If you found this helpful, don't forget to like, share, and subscribe for more pharmacology made clear.